Good day, and welcome to this lesson on respiratory clinical pathophysiology. In the previous lesson, we looked at what determines ventilation and perfusion, and we said, ventilation is not just counting respiratory rate. It depends on respiratory rate, depth of breathing, open airways, and strength of breathing muscles. Perfusion refers to blood flowing through the lung vessels. Even if air reaches the alveoli perfectly, oxygen cannot enter the blood unless blood flows past those alveoli. If perfusion is reduced or blocked, oxygen transfer fails, despite normal ventilation. By the end of this lesson, you will be able to explain perfusion and recognize when blood flow problems limit oxygen entry into blood. Use ventilation and perfusion mismatch to explain hypoxemia, and link it to common examples such like pneumonia, asthma, and pulmonary embolism. What do hypoxemia and hypercapnia indicate? Let's start with hypoxemia. It means low oxygen in the blood. But oxygen delivery depends on more than peripheral oxygen saturation alone. Oxygen delivery is influenced by ventilation, perfusion, cardiac output, and hemoglobin level. So, oxygen can be administered and delivery can still fail if the mechanism behind oxygen transfer is impaired. Early signs include fast breathing, restlessness, and anxiety. Late signs include cyanosis and reduced consciousness. If you wait for late signs, deterioration is already advanced. Early recognition depends on noticing subtle change, especially rising respiratory rate and increasing effort. Hypercapnia. Carbon dioxide is a waste gas removed by ventilation. Hypercapnia means that carbon dioxide is building up in the blood. Hypercapnia usually indicates ventilation failure, effects such as headache, drowsiness, confusion, and respiratory acidosis. This distinction is critical. Note: hypoxemia is oxygenation problem, while hypercapnia is ventilation problem. They may coexist, but they are not the same. Carbon dioxide retention often signals that breathing is no longer effective. When does compensation become failure? Compensation increases energy demand. The respiratory muscles must work harder and harder. At this stage, the patient may still appear stable, but risk is rising. Compensation is not recovery. It is the body working harder to prevent collapse. If the stress continues, respiratory muscles fatigue. Decompensation begins. When oxygen drops or carbon dioxide rises, the body tries to protect itself. Signs of compensation includes breathing faster, breathing deeper, and using accessory muscles. Signs of decompensation includes slowing or shallow breathing, reduced consciousness, and falling oxygen despite support. Bear this in mind. A patient who appears to be calming down, that is, slower breathing, may actually be tiring, not improving. In summary, we saw what hypoxemia and hypercapnia indicate. We said that hypoxemia means low oxygen in the blood. Oxygen delivery is influenced by ventilation, perfusion, cardiac output, and hemoglobin level. And for hypercapnia, carbon dioxide is a waste gas removed by ventilation. Hypercapnia means that carbon dioxide is building up in the blood. That is all for now. We shall continue the lesson in the next class. Thanks for watching. See you in the next lesson.